Tonight, we are joined by Dr. Rinki Murphy. Rinki is an endocrinologist, diabetologist, and physician working at Auckland DHB Counties Manukau Health. She is also an associate professor of medicine at the University of Auckland and has been a medical advisor for Diabetes Auckland since 2009. Rinki holds a PhD in genetics and epigenetics of diabetes and also manages to lead the national guidelines and database for monogenic diabetes. According to Grandma Google, in Ricky's spare time, she has also managed to complete over 50 published papers in peer-reviewed journals. I think that's pretty amazing. Tonight, Ricky will be sharing her knowledge on inequities in diabetes, medicine dispensing, health outcomes, and how to reduce inequities going forward.
So I'm delighted to talk with you about inequities in diabetes today. I was planning on talking about some new medications, but we've had a change in focus to this talk. So what I'd like to do is advance my slides. So firstly, just a definition of inequity. We know that people have differences in health which are unequal. But when they're avoidable, unfair, and just, that's when we use the term inequitable. And if we were to have equity-focused healthcare, then we'd be able to recognise that different people with different levels of advantage require the different approaches and resources to achieve more equitable health outcomes. So if we look at the cartoon, many of you may have seen this before. Equality is where we give everybody a box, but the equity example is where we give people who need to see over the fence in this figurative cartoon more boxes than the people who don't. However, in reality, we have the converse, where the people who need the most boxes are actually in the trenches, and the boxes are stacked high up for the people who least need it. And so, one of the key equity-focused healthcare is having services that have eligibility by deprivation or quintile 5 as a surrogate for that, and have healthcare services that are particularly focused on Māori and Pacific requirements, and have a different delivery model that is more tailored to vulnerable groups. So currently, what we have is some variation in healthcare quality and access, which aggravates inequities, particularly with relation to public-funded diabetes specialist service that can vary by region, particularly rural versus urban, but also within urban regions, we have differences in the access criteria, referral criteria to see a specialist. We also have variability in the quality and accessibility of diabetes care services across primary and secondary care across New Zealand. And of course, not many people are able to access private practice, specialist care, and self-fund guideline medications that are currently not funded. So what does that lead to? In terms of what I'll be covering today is who is getting left behind, and many of us will be familiar with these statistics. I'd like to go to medication dispensing statistics and how that may contribute to these health outcomes. I'll take you through a case history in a diabetes specialist clinic and how we could work to reducing these inequities. So firstly, who is getting left behind? We have our diabetes prevalence by age and ethnicity from our virtual diabetes register. And here in this graph, you can see that the prevalence of diabetes is highest in people of Pacific and Indian ethnicity. And this is a graph showing how at already in the mid-40s or even early 40s, we've got about 12% prevalence, which in Europeans in the blue line comes to a 12% prevalence in the mid-60s. So a 20-year difference in the same prevalence. And also the peak prevalence reaches about 50% in Indian and in Pacific people, intermediate in Māori here in the red, and lowest in European. So the majority of this diabetes is type 2 diabetes, particularly in the older age groups. However, there are cases of diabetes misclassification that occur across the age span, and I'm particularly keen on not missing very rare cases of monogenic diabetes and also type 1 diabetes that can present at any age and commonly may be misclassified as having type 2 diabetes when people actually present later in life. There are underpinning socioeconomic and genetic differences that underpin the difference in prevalence of type 2 diabetes by ethnicity. And ultimately, this difference in prevalence carries on through to when we examine how diabetes prevalence varies by ethnicity when we take into account socioeconomic deprivation. So this is a graph. I'll show you quite a few graphs with Wing Chek Chan initials, and he's a public health physician who provides counties Manukau DHB data very efficiently, and this is quite insightful in that quite large proportion of our New Zealand population who are of different ethnicities reside in South Auckland. There's a real mix of ethnic groups. And what we can see here is that even when we look at the orange bars, which are people in the most deprived areas, obviously is greater prevalence of diabetes compared to those who live in the blue bars in the least deprived areas. For every ethnic group, you can see that there is a much greater prevalence amongst Indian, Pacific, and also Māori. So even when we take into account socioeconomic factors, there are some additional differences by ethnicity such that these differences remain. What we know is that once one has developed diabetes, that diabetes control is linked to complications, and we can actually control glycemia with a range of methods, starting with diet modification, lifestyle, physical activity, and a range of oral medications as well as insulin as the injectable medications, and some new ones to boot. There is limited access to bariatric surgery that also helps with diabetes control, if not remission. And of course, attention to blood pressure and cholesterol and smoking cessation, because ultimately poorly controlled diabetes leads to blood vessel complications. And blood vessels are susceptible not only to high sugar, but also blood pressure and high lipids, and hence a focused, a multi-pronged approach to targeting all the risk factors of smoking and lipids and blood pressure, along with glucose, is required. So when we look at glycemic control, we know that HbA1c above 75 is a marker of poor glycemic control and is linked with poor outcomes from microvascular and macrovascular complications. And we see that with age, we have younger people tend to have higher proportions with poor glycemic control, with all the challenges of being in that age group. But you can see in the red Pacific and in the blue Māori that Māori and Pacific are highest in terms of proportion of people with poor glycemic control. And this proportion of poorly controlled diabetes across 3 of the DHBs that I have figures for in the Auckland region are increasing over the last 4 years. And particularly in the last 3 years, there's been a year-on-year increase by 10%, such that the 3-year change has been over a third increase in people with HbA1c that is poorly controlled. When we look at screening for complications, we looked at the published studies looking at screening rates and development of sight-threatening retinopathy. And again, we found that people of Pacific and Māori had higher rates of sight-threatening disease and lower rates of screening attendance compared to Europeans. And Asians also fared worse than Europeans in eye disease screening and outcomes. When we look at feet, we have highest risk of lower limb amputations among Māori, and this was published 5 years ago, even after adjusting for socioeconomic and specific risk factors like smoking, blood pressure, BMI, and lipids. You can see that the proportion without amputation is lowest in Māori, particularly in Māori men, and that tended to go up with age, smoking, and duration of diabetes, and interestingly, height. And the authors of this paper suggested that there could be issues around socioeconomic advantage, preventative foot care, and access to healthcare, as well as delivery of care that was underserving Māori as compared to other ethnic groups. In terms of renal failure incidence by ethnicity, here we see highest prevalence in Pacific people, followed by Māori, and death amongst people with diabetes by age and ethnicity. We this time see Māori having the highest case fatality. And whilst this may be associated with higher prevalence of other risk factors, particularly smoking may be a contributor, we still have these differences by ethnicity here. So when we look at medication dispensing, what can we see here that could inform us about what things we can do to change the inequities in diabetes? When we look at dispensing medications, which may be less than what you might estimate from prescribing information, because there is a step or two between being prescribed a medication and then collecting and having it dispensed, and then also in actually taking the medication. But here we have the proportion of people who have cardiovascular disease and should be at least on a statin, some form of antihypertensive therapy and antiplatelets, and the triple therapy prevalence is far from being complete, and only approximately 3/4 to 1/3 are actually on one or all three of these medications. And those prevalence figures or proportions haven't changed in the last 2 years. And it seems that we are not able to improve on these. And in terms of whether that proportion is different by ethnicity, there are some numeric differences with a trend towards lowest in Māori and similar in the rest of the ethnic groups, at least from the northern region DHBs. When we look at diabetes medication dispensing, so this is now looking at glucose-lowering therapies, again, if we look at the cohort who have HbA1c above 75, then we find that people who are dispensed with one of the hypoglycemic medications is the majority. But clearly people need to be on more because they have such high HbA1c. We know that just being dispensed one agent is not going to be sufficient. And the insulin is the only one on the list of medications that has unmatched or maximum ability to lower blood glucose. And it's simply the matching of people's requirement with the dose of the insulin and the complexity of this treatment that is the reason why people have persistent hypoglycemia. So there's some additional complications or at least additional complexity when people get started on insulin. Clearly the dose needs to be increased to match the targets that we're hoping to achieve. When we look at people who've had poor glycemic control, what does this vary by ethnicity? And again, European and other ethnic groups have the lowest prevalence of people who are not on insulin. So only 20% of people with an HbA1c above 75 are not on insulin, whereas for every other ethnic group, Māori, Pacific, Indian, there's much higher prevalence of people who are not on insulin. And so that indicates that we are having issues with treating people appropriately, having that discussion about insulin and making sure that the dose is right for people. So some of this is around educational access for healthcare providers. And given the recent advances, or at least new evidence around the new drugs for type 2 diabetes, I've been involved in generating some guidance for NZSSD management algorithm for type 2 diabetes, which has a lot of the existing initial management of diagnosis, starting with lifestyle and starting metformin, but a much more appropriate and rapid titration of medications than we've had in the past. The target HbA1c being 53 or below 53. And if someone's HbA1c is above 64, to actually start 2 agents rather than the one. The key change from previous guidance or guidelines is that, in keeping with the international guidance, people have cardiovascular or renal disease or heart failure, that they also initiate an SGLT2 inhibitor or a GLP-1 receptor agonist. If no cardiovascular or renal disease and no heart failure, a DPP-4 inhibitor such as vildagliptin would be indicated, and the consideration of starting insulin therapy if the HbA1c is above 90, and obviously if someone's suspected to have type 1 diabetes. Now, this is ahead of the Pharmac funding decision for the GLP-1 or SGLT2 inhibitors, and hence currently these are unfunded agents that cost a significant amount, and if the situation remains, it's going to aggravate inequities and certainly not help our health outcomes from diabetes. So, paradigm shifting new drugs for type 2 diabetes. The first class is the SGLT2 inhibitors, of which we currently have dapagliflozin registered and available in New Zealand for prescribing at a cost of $90 per month for a single daily tablet of 10 milligrams of Forxiga or dapagliflozin. Pharmac are currently considering empagliflozin for funding, and this also has improved cardiovascular outcomes, in addition to the class effect of SGLT2s in general that improve blood glucose, do not produce hypoglycemia on their own, lower body weight by about 2 to 3 kilos, lowers blood pressure, lowers uric acid and gout, improves heart failure and cardiovascular death, improves renal outcomes, and in the case of empagliflozin, also improves cardiovascular outcomes. So these can be considered as a statin equivalent and also as renal protective agents, and can be and should be commenced in anybody with a risk factor for either renal or adverse cardiovascular outcomes. And in fact, even without those indications, these are very good glucose-lowering agents that have a similar efficacy in glucose lowering to our standard metformin, sulfonylureas, and so forth that we're more familiar with using. The second class of agents that are paradigm shifting is the GLP-1 receptor agonists. Now, these are peptide analog hormones, so they, like insulin, have to be taken as a subcutaneous injection. And what we have available is exenatide at a cost of $220 a month for twice daily injections. The eye-watering $260 per month for once weekly subcutaneous exenatide. We also have once daily subcutaneous liraglutide or Saxenda, which is registered for the indication of weight loss at a cost of $500 a month. Similar, if halved, to the subcutaneous exenatide, although Saxenda will also improve blood glucose in people with diabetes. And these also have the advantage that they improve blood glucose. They don't have hypoglycemia when used on its own, and have the greatest weight loss, particularly with liraglutide or Saxenda, and have improved cardiovascular outcomes in the case of exenatide, and also dulaglutide, which is what Pharmac are considering funding as a once weekly preparation. They also have improved renal outcomes as a class. So now I'm going to take you through a case history of someone, a story that's based on someone I saw in an Auckland diabetes clinic, but clearly many of the details have been changed for anonymity and the pictures are not hers. These pictures are taken from Google after searching. So I'd like to introduce you to Mrs. KL, a 55-year-old woman I saw recently who'd had type 2 diabetes for 14 years. She is from the Cook Islands with past gestational diabetes with the last 2 of her 5 children. She had gained weight in each of her pregnancies and steadily thereafter to her current BMI of 38. She has moderate to severe diabetic retinopathy, stage 3 chronic kidney disease, and macroalbuminuria. She also had peripheral neuropathy and poor dentition. She was living with her 2 children, her youngest son and oldest daughter, daughter's partner, and 3 grandchildren. She had some dystrophic nails with a fungal infection and also poor dentition, and she'd had some toothache and issues with prior dental extractions. She attended her first appointment in September 2019 last year and had seen one of the registrars. She'd missed 2 of her intervening appointments at the diabetes clinic for follow-up, but attended my clinic in November just recently. She had changed her address and her appointment letter did not reach her. Her mobile phone number had to be discontinued, and so she was not able to be contacted very easily. Her last dispensed medications had been in July, and they included the usual ACE inhibitor, statin medication, metformin, amlodipine, and Novamix 30, 40 units twice daily. But this had not been dispensed since May 2020. So she was clearly out of insulin, but had been at least picking up the other medications. Her HbA1c had been 125 in September 2019, but had reduced to 86, and her creatinine had increased slightly and her liver enzymes were unchanged and near normal. So she was only taking her insulin every 3 days because she'd had low blood sugars. She had not taken any insulin at all for the past 6 weeks since her teeth were extracted. Her blood pressure was elevated at 164/90, and she had run out of medications for the last 2 weeks. She said she was only eating a bowl of rice at night or some sugary tea to stop having a hypo. She has 4 to 10 slices of white bread with sugar, dipped in tea for breakfast or just sugary tea or eggs. This was not unusual for her since her dental extraction, in fact, had been an issue longer term. She had calluses on the soles of her feet with redness but no sensation. And she had a number of other stresses, which included housing and finances. She was also grieving over her sister's death recently. So the key issue was food insecurity, and this is defined as unreliable availability of nutritious food and inability to consistently obtain this food. She had intermittent intake of quite carbohydrate-dense processed foods and binge eating, and one of the key concerns was around additional food costs that she had seen other members of diabetes team in the past, and simply couldn't afford the standard advised foods for diabetes. She also was struggling to pay for medications, and also had housing concerns with permanent affordable housing. And so having a WIN support letter was her key priority, and she was very glad to get this addressed to her and addressing her social issues. And only after this were we able to turn to diabetes management. So if we look through the additional food costs, and this was provided as an estimate from one of our dietitians as to what this might actually look like for someone with type 2 diabetes, it's an additional cost of $30 per week, and is something that this lady was struggling to afford. When we switched to diabetes control, switching her from Novamix 30 back to Lantus, the long-acting preparation, was more appropriate given her erratic and variable carbohydrate intake, with NovaRapid 5 to 10 units for low versus standard carbs in her diet. And the list of foods that she was regularly consuming was more easily able to be related to NovaRapid than a pre-mixed insulin that she was taking twice a day. Because her carbohydrates weren't regular and neither was breakfast and dinner, this approach gave her some more flexibility. We noted under the 6-month recall that once-weekly GLP-1 receptor agonists, if funded, would be most appropriate, as this would not cause any hypos and further weight gain. And she may well be able to come off the NovaRapid and reduce her Lantus significantly, if not halved. She had some possibility of language literacy and numeracy limitations, and hence seeing the duty nurse and going through the dosing for NovaRapid and blood glucose testing was really key, and having that phone follow-up every 2 to 3 days until her blood sugar was stable, now that she was able to be contacted, and making sure that she was confident with self-management, having her blood pressure reviewed, and liaising with the practice nurse of her general practice was our plan. Microvascular complications for follow-up, we took an opportunistic review by a podiatrist and tried to reschedule her appointments on the same day as her next appointment with retinal screening, for example, as coming to the clinic and having to catch 2 buses was a significant limitation for her. When we see the proportion of patients that are seen in diabetes specialist clinics, there's very different access of people who can attend a specialist clinic at the 3 DHBs that are in Auckland. What we do see is that the proportion of people who have persistent hypoglycemia is similar across all 3, and is only a quarter of those who have poor glycemic control. However, we do have a significant did not attend or did not inspire rate for diabetes specialist clinic, and this comes at as an opportunity cost for people who are booked and are not attending, and it's a real problem as to who and how we're going to reach people in our current system. And the highest rates of did not attend are actually for people with Māori and Pacific ethnicities, both across Waitemata and counties. So to turn to finally, how do we reduce inequities? The quality standards for diabetes care by the Ministry of Health, and this document is available on the internet. All people with diabetes will receive high quality, culturally relevant, structured self-management education that's tailored to the individual needs. And together with their whānau, they will be informed of and provided with support services and resources that are appropriate and locally available. Management of diabetes and cardiovascular risk. Everybody will receive medications as appropriate in accordance with their current recommendations, and those who don't achieve their agreed targets will have prompt access to expert help. Those who require insulin will be able to access timely expert help. So both of these statements are aspirational because on the ground they don't seem to be happening in terms of being able to receive guideline medications and being able to up-titrate insulin to in a timely way with expert help. And finally, in terms of delivery of systematic, high-quality diabetes care, that our service planning will be co-designed and culturally appropriate to improve care delivery and each DHB diabetes governance group will have access to the primary health organisation and DHB performance, and most importantly, will use this information to improve equity and quality of patient care throughout the PHO and District Health Board. Now, having not been on any of these governance groups, I am still uncertain as to how this data is used to drive greater equity and quality of patient care. So the key issues, in my view, I've listed as clinician factors: lack of time to provide opportunistic care when people drop in for other reasons than diabetes, workflow inefficiencies in terms of how we see our patients and what roles we play in a multidisciplinary team for those of us who are lucky enough to have a podiatrist, a dietitian, a diabetes nurse, and a health psychologist. Then we are able to work more effectively in our piece. But those of us who have to fulfill several of those needs can find this quite inefficient and time-consuming. Lack of structure for proactive recalls and monitoring of medication dispensing is not something that comes easily with our IT systems in secondary care, and maybe that's different in primary care depending on the software and things that you use for this. Lack of knowledge and skills in complex diabetes management. This is an area that's more easy for specialists and perhaps less so for general practice, where a person with diabetes is seen shoehorned between very different cases with very different needs. And familiarity with newer agents as well as the insulin dose titration may well differ by experience and case mix of your patients. And finally, perception of patient non-adherence and a one-size-fits-all approach clearly doesn't work, and we need to be more flexible and think around more deeply about non-adherence and how we can improve that. From the patient's perspective, competing demands, financial, social, and psychological, the complexity of treatment and the complexity of accessing care. It's really, when we look at what is on the 10 most important things to do today list for our patients, diabetes barely makes that list. There are lots of things going on. There's additional demands of COVID, losing jobs, trying to juggle rent, and other demands takes a huge psychological toll, and people can simply have no capacity to then look after chronic care for their diabetes, and then on top of that, diabetes treatment is not a take and forget medication like blood pressure and lipids. It requires the blood glucose monitoring in some cases, and quite complex regimens of having to take varying doses of insulin and remembering how to take medications before and after food several times a day. And some of the two new classes will help with the complexity of treatment in some cases. However, the complexity of accessing care still remains. Which pharmacy to go to that has the lowest cost, the whole idea of having co-payments, where to access care at, and whom to see is quite a difficult task to navigate. Confirming appointments for secondary care might not be easy for people who are working full-time and aren't able to answer their phone. Having different addresses or having to move adds a burden on patients. Simply having a number of medications and experiencing side effects without knowing which ones cause what can be quite bewildering, with new medications requiring dose adjustments. And finally, this just perception of healthcare provider, how well that connection is made, different beliefs about illness and treatment, all impact on patient factors that can impact on whether or not the medication is actually collected or even taken. So what kinds of system solutions can we implement or have a think about? Number one is removing financial and transport barriers for our vulnerable patients and moving to a system that rewards the provision of high quality and equity-based care rather than being simply visit-based. Having integrated IT systems that actually help both ourselves as clinicians in terms of seeing what is happening with monitoring medication dispensing and also providing patient support for navigating the healthcare. Clear instructions around being able to how to minimise prescription and GP visit costs, the time of work and eligibility for free or low-cost services. Guidelines embedded in electronic decision support and funded guideline medications are going to be helpful. Having the right clinician educational support with the right help at the right time when the patient is there. Having equitable access to secondary care specialists across New Zealand and patient resources available in a variety of engaging formats. So currently our patient resources are often provided by drug companies. The patient information that's available is not particularly suited for low health literacy. It's not engaging, it's not very illustrative, and hence we really need to move to trying to create some better ones that make it easy for the prescriber to then be able to direct some supportive patient-facing resources to help with adherence and expected side effects and how to adjust medications. Overall, an ambitious system solution would be to redesign the care process for people with diabetes and have greater transparency of what is available to whom, where, when, and at what cost, making sure that those people with the highest needs have the least barriers for accessing the care. So in terms of being able to have equitable or achieve equitable prescribing, we do need to use our PHO level data and also the national data to review prescribing and dispensing information for not only the old medications, but also when the new medications come on or become funded for type 2 diabetes. We need to make sure that they are how they're being prescribed, whether those with the highest clinical indication are actually receiving them, and whether there are discrepancies by ethnicity and socioeconomic status. There's a number of efforts already underway with query bills and dashboard and quality improvement teams that are identifying the proportions who have eligibility for the new medications or are not currently receiving the recommended guideline treatments such as ACE inhibitors or ARBs for people with microalbuminuria. And we also need to work with the data sharing activities that not only share data, but look at the practice level factors, such as the model of care, the cost of appointments, the length of appointments, the workflow differences in terms of nurse-led care, the use of community support workers, integrated prescribing pharmacists, or directed education of staff and secondary care support that go with better care and of which better prescribing is needed. We also need to consider patient experiences of accessing diabetes care and having the detailed information on patient benefits, eligibility for services, would help patients choose where they would like to be seen. And in other countries, there have been, we need some debate and discussion around these league tables or star ratings in some countries, which are designed for transparency and to drive up standards. Some really good work has been conducted by many people in various parts of New Zealand. One that I'm aware of is a effort by a group led by Marjorie Harwood to look at kai manaki as Indigenous health worker support for people who have poorly controlled type 2 diabetes, including a kaupapa Māori approach, which is called the Manatū program. And this is based around a information management platform called Mohio, which is integrated within the primary care patient management system for the data that is used for the study. And the Manatū approach has been designed by Māori and is for Māori, and it has workforces culturally relevant, competent, including the Kaimanaki, through a PHO-led system, and National Hawara Coalition are looking to evaluate this model, and we look forward to learning more about that, and hopefully that can be something that others can also adopt, should it be as effective as we all hope. So in summary, there is plenty of research showing disparities in diabetes prevalence and outcomes, but what we do need to do is use this data to close the loop in delivering high quality care to those who are getting left behind in a more proactive and systematic way. And we also need to test the different parts of developing, implementing, and evaluating equity promoting interventions that will ultimately reduce diabetes and cardiovascular burden across our most vulnerable groups. So with that, I thank you for your attention, and I'm really looking forward to some questions.
Oh, thank you, Rinki. That was amazing. Full of information to share with us. Can you hear me now?
Yes, thank you.
Yes. Okay, so we've got a couple of questions here, and so one of them's quite a long one, so I'll try and break it down into pieces for you. It says, at the other diabetes webinar in this series, the Australian doctor presenting talked about research that improved control early in diagnosis, especially in the first 10 years, impacted outcomes, even if control later was poor. If I remember right, he mentioned that after this control did not impact outcome as much, and I think said tight control could even be detrimental. Would this impact the target you would aim for in this case presented?
Yes, so very good question. Early on, good glycemic control has impacts on long-term complication outcomes independent of subsequent outcomes. So we know from a number of studies that early glycemic control is really important. Any detrimental effect of tight glycemic control is really related to hypoglycemia risk and the types of agents that are needed to achieve good glycemic control. And if you can achieve glycemic control with metformin, vildagliptin, and the new agents SGLT2 inhibitor, you can even throw in the GLP-1 receptor agonist. Those four do not cause hypoglycemia. They don't need to be used with a glucose threshold in mind. In fact, you can use them for people who don't even have diabetes, such as there's expanding indications for SGLT2s, for example. So I think some of the older studies that relied a lot on aggressive management are using insulin-based therapies. You do have to watch out for hypoglycemia, particularly if there is someone who has ischemic heart disease. But for the most part, it's really agent dependent, and avoidance of hypoglycemia is key.
Thank you. And then getting to the next part in that same question, we've got, secondly, would I be correct to assume if available, you would choose the weekly new agent injection as it would take the least effort to remember? And if not, can you explain your reason for this choice?
Yes, so I think there's a difference between the SGLT2 inhibitor class in terms of additional benefits beyond kidney benefits, which are greatest with the SGLT2 inhibitors. So if I had someone who had heart failure and or kidney failure, I'd use the SGLT2 tablet form just because they have superior benefits on heart failure and kidney function preservation. If they had side effects like urinary tract infections, which are the commonest with the SGLT2s, then I would go to a once weekly GLP-1. Or if someone had weight loss as their preferred side outcome beyond diabetes control, then the GLP-1 once weekly would be good. But GLP-1 receptor agonists are not superior for heart failure outcomes as SGLT2s are. They don't lower uric acid and gout. So there are some distinct advantages to using the SGLT2 inhibitor first.
And then the main question here. So when will we know if Pharmac will be approving some, any, or all of these new medications?
Yes, well, your guess is as good as mine. We have actually had some correspondence on the 9th of November to say that the decision is not made to proceed from the 1st of December, which we were disappointed about. But we are looking forward to an answer. The short answer is I don't know.
It's all right. It might be a Christmas present for us all, eh? Maybe for Christmas.
I'm hoping.
And then, do you believe pharmacists can help identify patients so that early implementation of improved medicine pathways is introduced, ideally to funded medicines as they become available?
I think pharmacists could have a very important role in signposting eligible patients and assisting with not only the prescribing pharmacists, but also non-prescribing pharmacists could have that case finding and signposting roles, as well as education around people who are unfamiliar with why they've been prescribed something. There are so many aspects to making sure that we case find and make sure that people are transferred over to these new medications as quickly as possible.
Great, thank you very much. Now, I think we have covered off the questions. There's a lot of thanks coming through already from people saying about how somebody says, fantastic as always, and great presentation. So, people are very happy with what you've provided this evening. Thank you very much.